So reproductive pathology. So let's get right into this. Polyhydramnios and oligohydramnios. What is polyhydramnios? Well, it occurs when the level of amniotic fluid is high. It's usually greater than 2,000 milliliters and less in late pregnancy. The fetal abnormalities associated with it is an instability of the fetus to swallow, to ancephaly, which causes esophageal atresia and tracheoesophageal fistulas. The maternal abnormality is associated with gestational, you got it, diabetes. And that is polyhydramnios for you. So what is oligohydramnios? Well, oligohydramnios occurs when there is a low amount of amniotic fluid. It would have been much simpler if they just said that in medical school, right? And that's usually less than 400 milliliters. And that's in late pregnancy as well. It's associated with the inability of the fetus to excrete urine into the amniotic sac due to a bilateral renal agenesis or posterior urethral valves in males. And oligohydramnios can result in something called Potter's syndrome. Potter's syndrome with oligohydramnios, more accurately described as a sequence or chain of events that may have different beginnings. So, like an absent kidney, cystic kidneys, or even obstructive ureters, by which all end up with the same conclusion, which is an absent or reduced volume of amniotic fluid. Okay. They also see hypoplastic lungs due to increased pressure on the fetal thorax. So that is poly and oligohydramnios. The next thing we're going to talk about is benign breast tumors. Okay, so a fibroadenoma is the most common breast tumor in women under 35. It's associated with cyclosporin A. That's important to know. That is very important to know. Half of women receiving cyclosporin. So first of all, why would somebody be receiving cyclosporin A? For a renal transplantation, right? They develop, half of these women develop fibroadenomas, which, like I said, is the most common breast tumor. But it's benign. In this setting, they are often multiple and bilateral. Okay? Multiple and bilateral. Histology, you get a proliferation of intralobular stroma. Alright, and you get duct epithelium that is not neoplastic but may be distorted by mass. They are usually well circumcised. They're grayish white. They're rubbery nodules with cleft-like spaces inside. So the signs and symptoms of these are it's usually painful or painless. It could be either one, but it's a discrete and movable mass. The size changes with menstruation, variation, or pregnancy because they're estrogen sensitive. They may involute or calcify after menopause, okay? So transformation of fibroadenomas to malignant breast cancer is extremely, extremely rare, okay? The management is generally conservative and observatory. So what about phylloides tumor of the breasts? This is a fibroadenoma variant that occurs in older women, usually greater than 50. It's a large, bulky, stromal mass of connective tissue and cyst. It's characterized by cystic spaces containing leaf-like projections. Don't worry about remembering that. Just leaf-like projections from cyst walls and myxoid contents. But it can be malignant, and that is when you get a cystosarcoma phalloides. Cystosarcoma phalloides. And that is when you get hypercellularity and mitosis that suggest malignant change. So the most common cause of bloody nipple discharge in women under 50 is an intraductal papilloma. The discharge may be serous or bloody, and that is a benign tumor of the major lactiferous ducts. Lactiferous ducts or sinuses, actually. It could be either one. So those are the benign breast tumors. You have fibroadenoma, phalloides tumor of the breast, which could progress to a cystosarcoma phalloides, which is malignant, and an intraductal papilloma. So now let's talk about breast tumors that are malignant carcinomas of the breast. So before we do that, let's talk about some general characteristics of these. So the epidemiology and general characteristics. It's the most common cause for women in the U.S. of cancer. In the United States. That is, you think you're going to be tested on that? You better believe it. It produces the second highest cause of cancer deaths in women and in all adults. The breast mass in women is usually greater than 50, and that's the carcinoma ones, until proven otherwise. So if she's greater than 50 and she's got a breast mass, that's cancer until proven otherwise. It's most common postmenopausal breast lesion. They arise, some more facts is they arise from the mammillary and duct epithelium or lobular glands. And now pay attention to this. It occurs most frequently in the upper outer quadrant. I know we all learned that in med school, of the breast. So these tumors metastasize to what nodes? That's what they're going to ask you on the boards. They met to what nodes? The axillary nodes. The axillary nodes. And that is the most important prognostic factor in breast cancer, unless you have like distant metastasis that's present, etc. The internal breast carcinomas metastasize first to the internal mammary nodes. So if you get distant metastasis, lungs is the most common place that it metastasizes to, followed by bone, followed by the liver, brain, and ovaries. So breast cancer, I just want you to remember it's going to metastasize to the lungs or the bone. Alright, so you get an overexpression of the ER or PR, which is estrogen and progesterone receptors, or of the HER2, okay, which is the EGF receptor. So let's see here. We can have estrogen, progesterone receptor positive tumors. And these affects therapy and prognosis, or this can be treated with a drug called, what drug would I treat estrogen, progesterone receptor positive tumors with? That's right, tamoxifen. Alright, and that usually has a better prognosis. And then we can have the HER2 or the, I'll just write it in there for you, it's too much to say. So the HER2 or the CERB beta 2 tumor is it's a proto-oncogene that exhibits gene amplification. So when this happens, it's the worst prognosis. Okay, so these are the two main types of most frequently breast cancer here. So let's talk about some risk factors. So that's an overview of breast cancer for you that's malignant. So let's go back and talk about these. Actually, before we do that, we're going to talk about some risk factors. So risk factors for breast cancer. All right, so age is number one. Genetically, some risk factors may include the BRCA1 or 2 mutation, P53 mutation, the HER2, like we said, which confers a terrible prognosis, the RAS, this one's not that big of a deal, and the first degree female relatives with breast carcinoma. Alright, so any age of prolonged estrogen stimulation can cause this as well. That's a risk factor. So fibrocystic disease with atypical ductal hyperplasia is a big deal. A high animal fat diet. Now the risk is not increased by fibroadenoma or non-hyperplastic cyst. That is important to know. Okay, the risk is not increased by fibroadenoma or non-hyperplastic cysts. So let's talk about some Paget's disease of the nipple. Paget's disease of the nipple. This is an eczematoid lesion of the nipple or areola. The history of Paget's is it looks like a melanoma. It looks like a melanoma. It's large cells surrounded by a clear halo. Large cells surrounded by a clear halo. They invade intraepidermally. So the gross appearance is going to be a rash with a possible nipple retraction. Basically a DCIS that extends to lactiferous ducts and areolar skin underlying invasive ductal carcinoma. That's often present. And now moving right along to ductal carcinoma. This is the most common type of breast cancer. Most common type of breast cancer is ductal carcinoma. Once again, the most common type of breast cancer is ductal carcinoma. Don't remember that. It's infiltrating and it's invasive. It's the most commonly found mass in women greater than 50. So if you see a mass in a woman greater than 50, start thinking ductal carcinoma until proven otherwise. Histologically, these are tumor cells that form bunches of ducts, cords, islands, and glands that are embedded in a dense fibrous stroma. The gross appearance may be a gray-white tumor with stellate morphology. Stellate morphology, reactive hyperplasia or fibroplasia, which is desmoplasia that leads to gritty induration. This is the worst prognosis of any breast tumor. The worst prognosis of any breast tumor, and it's the most common found mass in women greater than 50. So you see the problem here? 1/3 of these have the HER2 CERB beta 2 amplification gene. So 1/3 of them have that. You also have infiltrating or invasive lobular carcinomas. And lobular carcinomas frequently are multifocal and bilaterally. Histologically, you're going to see an Indian fly. An Indian fly is your buzzword for lobular carcinoma on the boards. It's orderly cells arranged in a linear arrangement or a bullseye arrangement in concentric circles. So that is an infiltrating invasive lobular carcinoma. Let's see here. We also have inflammatory carcinoma. This is not a true inflammatory process, but more lymphedema. So histologically, you're going to see tumor cells with plugs of subdermal lymphatics, which is going to lead to erythema and swelling. But the sweat glands fixed open but cannot expand. So you're going to get a dimpled, this is a buzzword, peau d'orange. Peau d'orange. And that is with inflammatory carcinoma. You see a peau d'orange or orange pill appearance. This has a very poor prognosis. Very poor prognosis. Now, invasive carcinomas, they have a better prognosis. So let me clear some of this out so we can talk about that. So invasive carcinomas, they have a better prognosis. You can have a tubular carcinoma, which develops in the terminal ductules. And they may develop bilaterally. Then you can have a mucinous. And remember here, I'm only just listen to what I'm saying, but what I'm writing in is your buzzwords and what you really need to know. You can have a mucinous colloid carcinoma, and that's clusters of tumor cells that float in mucin. And you usually see this in elderly women. And then you can have a medullary carcinoma. Now, the medullary carcinoma is associated with the BRCA1 mutation. Now, histologically, you're going to see a lymphocytic infiltrate here. You want to see a lymphocytic infiltrate around large pleomorphic cells with scant stroma. Now, the gross appearance is going to be a little different. It's going to be bulky, soft, and it's going to have a fleshy consistency. So that is malignant breast tumors, and I hope that cleared up a bunch of stuff for you with the benign and the malignant breast tumors. So let's talk about cervical pathology. So we're going to talk about cervicitis, and right here is a good picture of some cervicitis. The most cervical pathology stems from the effects of what? What do you think that would be? Sexually transmitted diseases. Now, cervicitis, that's inflammation as the name suggests, that typically occurs in the transformation zone. Typically occurs in the transformation zone. It is caused by ascending infections, most commonly chlamydia. I know a lot of people were thinking E. coli, but no, it's chlamydia and gonorrhea. Now, chlamydia and gonorrhea account for more than 50% of cases. Some other causes may be tunica vaginalis, candida can do it, HSV2, and HPV can all cause cervicitis. Now, you can have acute cervicitis or you can have follicular cervicitis. Those are the two cervicitises that you can have. Acute cervicitis presents with a vaginal discharge, bleeding, pain, dyspareunia. If untreated, it can cause chronic cervicitis, which increases the risk of what? Infertility. Okay? Now, follicular cervicitis is a subtype caused by, do you know? Chlamydia trachomatis. Chlamydia trachomatis causes follicular cervicitis. It is a common cause of neonatal conjunctivitis and pneumonia. Histologically, it's characterized by lymphoid germinal centers, right, and vacuoles containing reticulate bodies. All right, so let's talk about the Pap smear. This is a screening test used to detect squamous dysplasia and cancer. Okay, that's what we're looking for. It can also be used as a tool to evaluate hormone status. To get an adequate sample, it must be taken from the squamino-columnar junction, which is the transformation zone cells. So let's write that in there. The squamo-columnar junction. Now, it must include both metaplastic squamous cells and mucus-secreting columnar cells. Now, abnormal Pap findings include dysplasia or cancer, and they're characterized by a coleocytic atypia. That's coleocytic. Coleocytic atypia with nuclear enlargement, nuclear hypochromasia, a coarse chromatin granule, and a perinuclear halo. Cervical intraepithelial neoplasms, especially which ones? Can you remember which ones are associated with HPV? Well, it's HPV 16, 18, 31, and 33. Those are the HPVs that are associated with cervical intraepithelial neoplasia. Or as some people like to call it, cervical cancer. Now, the risk factors include early sexual intercourse, multiple partners, smoking, birth control pills, and immunodeficiency. HPV infects immature basal cells of squamous epithelium and immature metaplastic squamous cells at the squamo-columnar junction. Now, the viral proteins, this is important, so make sure you hear this. The viral proteins of HPV, which are E6 and E7, Those are the viral proteins of HPV that inactivate cell cycle regulation. Specifically, E7 or E6 does the P53, and the retinoblastoma gene is done by E7. So that's how you get CIN, or cervical intraepithelial neoplasia. Now there's three subtypes. You got CIN1, 2, and 3. So CIN1 is dysplasia involving the lower 1/3 of the epithelium. CIN2 is dysplasia involving the lower 2/3 of the epithelium. And CIN3 is defined as carcinoma in situ. Okay? So the histopathology is cervical dysplasia that's characterized by disordered epithelial growth, as you might expect. So you get a loss of polarity. Like I said, coleocytes are seen where you see a clear halo surrounding a hyperchromatic atypical nuclei beginning at the basal layer and extending outward. Carcinoma in situ is characterized by atypical changes extending through the entire thickness of the epithelium, and it has not invaded the basement membrane, so it's considered a precancerous lesion. Now, what's the vaccine called that we use against HPV? That's right, Gardasil. Gardasil is the vaccine for HPV, but mainly these types down here. Okay, it's a vaccine against HPV. It's now approved for also both males and females. So there's one last thing we got to talk about here. I'm going to get a new page for it, but we're still talking about the same thing. Is invasive cervical carcinoma. Invasive cervical carcinoma. This is cervical cancer that is now the least common gynecologic cancer due to success of what? The Pap smear. It typically presents with a malodorous discharge and irregular bleeding, which is often postcoital. The vast majority is squamous cell carcinoma. Adenocarcinoma accounts for about 5% of cases. It involves dysplasia, carcinoma in situ that leads to invasive carcinoma. Pap smear is the screening test of choice. So get a Pap smear, ladies. Very, very important. Very simple. It can discover cervical dysplasia before it progresses to invasive carcinoma. Dysplastic cells demonstrate coleocytosis. Coleocytosis, which is cellular changes in cells that appear to have a halo nuclei on cytological exam. It spreads by direct invasion. Direct invasion of nearby structures, so it can infiltrate what? The bladder and or the ureters. It can also invade the rectum, the vagina, and other adjacent structures. So what is the most common cause of death in these patients? That's right, renal failure. That's pretty high yield to know. Renal failure is the most common cause of death in patients with invasive cervical carcinoma, unfortunately. Invasion of the bladder and the ureters leads to urethral obstruction, so you get hydronephrosis and post-renal failure. Remember, post-renal failure. Not pre or prerenal, but post-renal failure and invasive cervical carcinoma. All right, so common breast conditions. So let's talk about some common breast disorders. Well, you can get fibrocystic changes. Let me change that for you, sorry. All right, so you can get fibrocystic changes, and this happens to be the most common painful breast mass in women of childbearing age. So the clinical presentation is extremely common. You see multiple often bilateral lumps. You also see nodular impurities exhibiting mid-cycle tenderness, and you most often occurs in the upper outer quadrants. So that is the fibrocystic changes associated with common breast conditions. It's associated with a slightly increased incidence of cancer when epithelial hyperplasia is marked. The risk of cancer is clear when hyperplastic epithelium demonstrates atypia. So for non-proliferative and proliferative types, you get an increased risk of cancer in proliferative patterns of change. So you get the non-proliferative fibrocystic type. You see fibrocystic changes, but there is no risk of cancer. No risk of cancer in the non-proliferative fibrocystic change. You will see fibrosis, so you're going to see hyperplasia of the breast stroma or cyst rupture. Cysts are going to be fluid-filled. They're going to drainage confirms a cyst. You see hemorrhagic fluid that appears blue through the wall. They call that a blue dome cyst. All right, and you can also see apican metaplasia. You can also see apocrine metaplasia. So what about the proliferative type? The proliferative fibrocystic change gives you an increased risk of cancer. So that's the difference. You get a sclerosing adenosis, where there's well circumscribed and swirling and crowding of ducts and acini within a lobule. It's associated with the fibroidic stroma and microcalcifications. You can also see papillomas, which are branching epithelial hyperplasia, and apican metaplasia occurring within a duct. Let's pull this over a little bit. Let's see here. And you can also see with the proliferative type atypical hyperplasia, which may be ductal or lobular, and that's due to estrogen stimulation. So cells containing an acquired genetic effects found in carcinoma, they have a very similar in appearance to carcinoma in situ. So now let's talk about some other breast conditions, and that takes us to fat necrosis. So fat necrosis is benign and painless lump that forms as the result of prior trauma to the breast tissue and may be visible on a mammogram. And that's about all you need to know about fat necrosis. It's usually a female that's been beaten, that's coming into the office acting weird. That's usually fat necrosis. Let's see here. Gynecomastia. This is enlargement of the male breast, usually in response to relative hyperestrogenism. It's commonly seen in patients with what? Cirrhosis, right? Because the liver processes estrogen. So it can also occur in certain types of testicular tumors, especially a Leydig cell tumor. So a Leydig cell tumor can cause gynecomastia, as well as puberty, old age, and Klinefelter syndrome. The gynecomastia in cirrhosis is due to decreased breakdown of estrogen secondary to decreased metabolic capacity of the fibrotic liver. Some drugs that can cause gynecomastia, let's write these in here. Number one is spironolactone. Digitalis, cimetidine, alcohol, and what's the last one? We all know ketoconazole. Well, if we didn't know, we know now. Types of nipple discharge. You can get galactorrhea, which is a physiological manifestation of prolonged sucking or sexual intercourse. You can also get a prolactinoma. That can lead to galactorrhea. Or you can get primary hypothyroidism, where the excess TRH released because of serum T4 or thyroxine is low, so you get TRH stimulates prolactin. So that's how you can get galactorrhea from hypothyroidism, because the TRH is stimulating the prolactin. You can also get a purulent discharge, which is acute mastitis. This occurs during breastfeeding or lactation, so you need to know that. Let's write that in there. You see acute mastitis in breastfeeding, okay? And there's usually milk entrapment and skin trauma that predisposes you. What is the main cause of acute mastitis, do you think? That would be Staph aureus. It's the most common cause. You can also see a bloody discharge, which is usually an intraductal papilloma or a ductal carcinoma, if you see a bloody discharge. If you see a brown-green discharge, you think plasma cell mastitis. So let's write those in there for you. And plasma cell mastitis is also known as mammary duct ectasia. Okay? So now that takes us on into disorders of sexual differentiation. All right, so disorders of sexual differentiation. Let's first talk about normal sexual differentiation. As an individual defaults to female differentiation unless something like hormones dictates otherwise. So sexual differentiation, let's talk about some definitions. Karyotypic sex is the genetic sex. The Y chromosomes contains the testes gene, which we all know. Gonadal sex is testes versus ovaries. Ductal sex is the Wolffian and Mullerian ducts, okay? Now the Wolffian ducts or the mesonephric ducts become the epididymis. Write that in there. The epididymis, seminal vesicles, and the vas deferens. Now, the Mullerian ducts or the paramesonephric ducts become the upper vagina, the cervix, the uterus, and the fallopian tubes. So that is the difference with the ductal sex. You have Wolffian or mesonephric, so it's M for M, or M for W, sorry, ducts, which become the epididymis, the seminal vesicles, and the vas deferens. And you have the Müllerian or paramesonephric ducts, which become the upper vagina, the cervix, the uterus, and the fallopian tubes. And then in sexual differentiation in number 4, you have the phenotypic sex, which is the genital sex or the external appearance. Now, like I said, the Y chromosome contains the testes genes, so that determines male differentiation. Germinal tissue becomes testes. Now, the Müllerian inhibiting factor, MIF, Müllerian inhibiting factor is synthesized by what? The Sertoli cells. Synthesized by the Sertoli cells. So that causes apoptosis of Müllerian tissue, right? So Müllerian inhibiting factor helps you to be a guy, okay? Now, female testosterone is from the Wolffian duct development, because the Wolffian duct is responsible for all the epididymis, the seminal vesicles, and the vas deferens, and mostly the male parts. So females have testosterone too. So fetal testosterone comes from the Wolffian duct development. Now, fetal dihydrotestosterone, or DHT, which is the active form of testosterone, comes from the prostate. DHT comes from the prostate, and where else? Phenotypic development. Phenotypic development, like examples, genitalia in female is until the dihydrotestosterone is present, which is the active form of testosterone. So an absence of a Y chromosome leads to a default female differentiation. So the germinal tissue becomes the ovaries. The Wolffian structures undergo what? Apoptosis, and the Müllerian structures develop. It's really that simple. So now let me erase this and we'll talk about each one of these. So what is a true hermaphrodite? This is a very rare individual with ovarian and testicular tissue. Ovarian and testicular tissue. This is very rare. The cause is fusion of two sperm. Fusion of two sperm, one X carrying sperm and one Y carrying sperm with a binucleated ovum. So the karyotypic sex will be 46XX. 46XY, 45XXY, and 47XXY. The one I want you to remember, 46XX. The gonadal sex, the testes and the ovaries are present in one or two anatomical variations. Number one gonad on each side, or number two, the big one that you need to remember is combined gonads, which is known as ovotestes. Ovotestes. Now, the ductal sex is often mixed, and the phenotypic sex is ambiguous genitalia. Okay? So that is a true hermaphrodite. So what about a pseudo-hermaphrodite? They may be male or female. It describes the genetic or karyotypic sex. The gonads and genotype match, but the phenotype, which is the appearance of the external genitalia, do not. Okay? So the karyotypic and gonadal sex is normal. So female hermaphroditism is 46XX. And for the male, it's 46XY. So the ductal sex now of females is normal Müllerian structure. And for the male, its Sertoli cell MIF eliminates the Müllerian structures. But the Wolffian ducts do not develop. That is very important. The Wolffian ducts in the male do not develop. But it's the Sertoli cell MIF that eliminates the Müllerian structures in the male. So that's the ductal difference. Now, the phenotypic sex, females have ambiguous virulized genitalia. Males have ambiguous or female external genitalia as well. So let's see here. So what about male pseudohermaphroditism? Male pseudohermaphroditism is the most commonly caused by androgen sensitivity syndrome. Androgen sensitivity syndrome is what causes male pseudohermaphroditism. Androgen sensitivity syndrome, or testicular feminization is another way of saying that, is the most common form of male pseudohermaphroditism that results from a defective androgen receptor. Phenotypically, they are females, but the testes and karyotype of a 46XY. So what about female hermaphroditism? This is most commonly caused by congenital adrenal hyperplasia. Congenital adrenal hyperplasia is what causes female pseudohermaphroditism. So the ovaries are present, but the external genitalia are virulized or ambiguous. It's most often caused by increased androgenic hormones and congenital adrenal hyperplasia, an androgen secreting adrenal or ovarian tumor in the mother, or hormone administration to the mother during pregnancy. The karyotype would be, well, you tell me, what would the karyotype be? That's right, 46XX. So for the gonads and ducts, the ovaries and Müllerian structures are there. So let's talk about androgen insensitivity syndrome. This is testicular feminization with the 46XY. It's caused by a defect in the androgen receptor. Defect in the androgen receptor resulting in normal appearing female with the 46XY karyotype. So it presents with female external genitalia with sparse pubic hair with a rudimentary vagina with an absent uterus and fallopian tubes. Now the pathophysiology is the failure of the body to respond to the presence of testosterone. That's what they're going to ask you about. Failure of the body to respond to testosterone. Because testes are present, Sertoli cells produce Müllerian inhibiting factor, which causes regression of, remember, the paramesonephric ducts, or that's another way of saying the Müllerian ducts. So you get absent female internal genitalia. So let me repeat that to make sure you understand that. Because the testes are present in androgen insensitivity syndrome, or testicular feminization, the Sertoli cells produce Müllerian inhibiting factor. All right, when you think Müllerian, think girl. And it causes a regression of the paramesonephric, or the Müllerian ducts, which causes absent female internal genitalia. All right, very good. So let's see here. This process normally occurs in all males. Testosterone is required for the presence of the Wolffian ducts. So Wolffian ducts will also regress, so there is no male internal genitalia. Patients will have neither set of internal genitalia. External genitalia will be phenotypically female in the absence of androgen stimulation. So patients are at risk for testicular malignancy because of the high incidence of intra-abdominal testes. Okay? So the testes are surgically removed to prevent malignancy. That's androgen insensitivity syndrome. The hormone levels, they're going to have an increased testosterone. They're going to have an increased LH. And they're going to have an increased estrogen. So now let's talk about 5-alpha reductase deficiency. Now 5-alpha reductase converts what? Testosterone to dihydrotestosterone or DHT in the peripheral tissues. Now dihydrotestosterone is required for normal masculization of the external genitalia in utero. So genetic males with a 5-alpha reductase deficiency are born with what? Ambiguous genitalia. Example, male pseudohermaphroditism. So increased testosterone causes masculinization of genitalia at puberty. Now, their testosterone and estrogen levels are normal, but the luteinizing hormone can be normal as well or increased. That throws a lot of people. Their test levels are normal, and their LH can be either normal or increased. So that's 5-alpha reductase deficiency for you. So the next thing, I know that was a lot, but you know, gotta know it. So let's talk about gestational trophoblastic disease. All right, this is a molar pregnancy or a benign gestational trophoblastic disease. So 90% of molar pregnancies are what? Hydatiform moles, complete hydatiform moles. Complete hydatiform moles. Alright, what that means is 1 or 2 sperm fertilize an empty egg. So all genetic material is parentally derived. So you get a duplication of the haploid sperm, and then that causes all the placenta and no fetus. So that's what you're seeing in this picture here. 90% of complete moles are the result of fertilization of an empty egg by 1 sperm. The product is 46XX due to the duplication of the haploid sperm. And 10% of complete moles are the result of fertilization of an empty egg by 2 sperm. So I'm going with the 90% every time. An empty egg by 1 sperm. %90 of the time. 10% it'll be an empty egg by 2 sperms. I always thought that it was always with 2 sperms, but no, that's only 10% of the time. And that's what they tell you. That's what they tell you in medical school. It's usually by an empty egg by 2 sperms, but no, 90% of the time it's an empty egg by 1 sperm. Now the products can either be 46XX or 46XY due to dyspareunia. So there's hydrophic degeneration of chronic villi. This leads to a cluster of grapes, or a cluster of grapes appearance, with no fetus on the pelvic ultrasound. No fetus on the pelvic ultrasound. It's a classic snowstorm appearance. These are all buzzwords for you. Classic snowstorm appearance is only seen with really old ultrasound machines from the 1970s, but they still may show up on exams. So make sure you know that snowstorm appearance, all right? But more likely, on the pelvic exam, you're going to be tested on the cluster of grapes. So common symptoms, you usually see vaginal bleeding, vaginal passage of the grape cluster hydrophic molar vesicles. You see an anemia. You also see uterine sizes that are greater than the dates they should be, like the examples, the uterus is larger than expected for the gestational age. Diffuse trophoblastic hyperplasia. You're going to see highly increased serum HCG levels relative to values observed in normal pregnancy. But less common, but classic symptoms of complete moles are hyperemesis, gravatum of gravidarum, which is the extreme morning sickness. You see preeclampsia before 20 weeks of gestation. You see theca luteal ovary cysts. And you also see hyperthyroidism. Don't worry, I'm going to put that back up there for you. So these are the 4 things that you see with the classic signs and symptoms of complete moles. Now the hypothyroidism, that can throw a lot of people. HCG is an analog of what? Luteinizing hormone. Luteinizing hormone has the same alpha subunit as thyroid stimulating hormone. So the highly increased HCG levels in complete moles may cause hyperthyroidism, and that's how that works. Now that's pretty cool, because a lot of people, they're going to test you on that, and a lot of people overlook that. So now let's talk about the 10%, since we've talked about the 90%, just to put it in there. So now, 10% of molar pregnancies are partial. Partial hydatiform moles. Now, 2 sperms simultaneously fertilize an egg in this. Remember I said that was 10%. A process called diandry. Remember, part of it is just knowing the language. Diandry. That's when 2 sperms simultaneously fertilize an egg. So you get an abnormal placenta. And you get an abnormal fetus. Which is ultimately non-viable. Now this is a triploidy. But remember, it's just 10% of the time. So these are your zebras. So you get a 69XXY. That's your karyotype. So you get a 23X from mom, which is a duplicated set from dad, is the most common. You can also have a tetraploidy, or higher multiples are possible if more than 2 sperm fertilize an ovum. But don't even worry about that. You're not going to be tested on that. The signs and symptoms, you have much less severe than for a complete mole, okay? Because this is a partial mole. The most common presentation is late first and early second trimester vaginal bleeding. That is the most common presentation. Normally or only slightly increased serum HCG levels, and that is not diagnostic. Remember, in a complete mole, they're off the charts. But this is only slightly increased in a partial hydatiform mole pregnancy. So now let's talk about choriocarcinoma. Choriocarcinoma. This is a malignant gestational trophoblastic disease. Malignant gestational trophoblastic disease. A complete hydatiform mole is the most common precursor to what? Choriocarcinoma, right? It's the 90%. A complete hydatiform mole is the most common precursor to choriocarcinoma. Histologically, there are no chronic villi. You get a mixed proliferation of trophoblastic cells, so cystiotrophoblasts, which secretes HCG, and cytotrophoblasts. Now, on the gross appearance, you have a soft yellow-white tumor with large areas of ischemic necrosis and hemorrhage, secondary to rapid, aggressive growth and invasion of adjacent myometrium, blood vessels, and lymphatics. Now, in choriocarcinoma, the HCG levels are off the freaking roof. Because remember, it comes from a complete mole. We already talked about that. Choriocarcinoma is associated with an increased frequency of theca luteal cyst. Because theca-luteal cysts are stimulated by what? HCG. So that makes complete sense. Now this one with choriocarcinoma, you can get a widespread metastasis, and it usually goes in females. Where's it go? The lung, and then the vagina. Those are the two I want you to remember. But it can also go to the brain, the liver, and the kidney. But the lung and the vagina is the two that I want you to remember with choriocarcinoma. Okay? So let's talk about gestational choriocarcinoma. So gestational. Gestational choriocarcinoma. Alright, so what do we know about it? Well, it expresses a paternal antigens capable of evoking a maternal immune response. So it's strikingly responsive to what? Chemotherapy. Great example of that is it is highly responsive to methotrexate with a 100% remission and high cure rate. So that is incredible. Definitely need to know that. Just remember its response to chemotherapy. Or actually, it responds to methotrexate. And it has 100% remission and high cure rates versus non-gestational choriocarcinoma, which is a more stubborn and unresponsive to therapy. Alright, so that's gestational trophoblastic disease. I think we covered everything they could possibly test you on there. So now let's move on to gynecological cancer epidemiology. So gynecological tumor incidence and prognosis. Endometrial cancer is about 6% of total female cancer. Total. It is the most common and has the best. Endometrial cancer has the best prognosis. Ovarian cancer is about 3% of total female cancers. and it has the worst prognosis. You do not want to get ovarian cancer as a female. Okay? So endometrial cancer has the best prognosis. Ovarian cancer has the worst prognosis. The incidence of cervical cancer has been drastically decreased due to the advent of the Pap smear screening test. Among the other major gynecological cancers, such as ovary and endometrial, it now has the lowest incidence, which is less than 2% of total female cancer. So cervical cancer we're doing much better with treating that in terms of epidemiology. So let's talk about non-neoplastic ovarian disorders. So what do we know about polycystic ovarian disease? Well, the LH-FSH ratio is greater than 2 to 1, with a high testosterone and a high estrogen. So you're going to see a lot of muscle relaxation, so you can take it. The classical presentation is an overweight young woman presenting with these signs: oligomenorrhea, hirsutism, that's the one I want you to remember, virilism, infertility, and insulin resistance. The insulin resistance is seen in about 50 to 70% of women with polycystic ovarian disease. Now, the pathogenesis is very poorly understood, but you have a high amplitude of GnRH pulses, which leads to a decrease or an increase in pituitary LH, which then leads to an increase in ovarian theca interna androgen synthesis. Remember, theca interna, not theca externa. And then you have an increased androgen aromatization to estrogens in adipose tissue. So polycystic ovarian disease is also related to insulin resistance because insulin, the theca cell secretion of androgen, and inhibits hepatic sex hormone binding globulins. So therefore you get an increased free androgens. You have less sex hormone binding globulins because of the insulin. So you're going to see a decrease in FSH, which will cause follicular degeneration with fluid-filled cyst. Hence, that's why they call it polycystic, right? It's because of the decrease in FSH. You'll have an increase in androgens, which leads to hirsutism, like I told you to remember, which is an increase in hair growth, like a male pattern hair. You're going to have increased estrogen, which causes an increased risk of endometrial, breast cancer, because of the prolonged nature of the stimulation. And the diagnosis with labs, how do you diagnose this? You do an ultrasound, obviously, but you also look at the LH-FSH ratio. If it's greater than 2 to 1, that shows polycystic ovaries are usually there. You treat this with over-the-counter, blanking here, OCPs. You treat it with OCPs. So let's talk about follicular cyst. This is fluid accumulation in the graphene or the mature or previously ruptured follicle. This is the most common ovarian mass. Follicular cyst is the most common ovarian mass. The rupture of this presents with sudden pain and sterile peritonitis. It's associated with hyperestrogen, okay? So what about the corpus luteum cyst? Well, this is fluid. Example of fluid would be blood, which accumulates in the corpus luteum during pregnancy. This is the most common ovarian mass during pregnancy. Most common ovarian mass during pregnancy is the corpus luteal cyst, and the follicular cyst is the most common ovarian mass. Most regress spontaneously. So what about the theca lutein cyst? This is a cyst lined by luteinized theca cells. It results from gonadotropin stimulation. gonadotropin stimulation. It's often multiple and bilateral and is associated with two things: choriocarcinoma and hydatiform moles. Alright, so what do we know about chocolate cyst? If you ever see the word chocolate cyst, that is a straight buzzword. It's endometriosis occurring in the ovaries. So you get a monthly hemorrhage or a creation of a blood-containing cyst. Now it varies with the menstrual cycle. It's also known as an endometrioma. Endometrioma. Chocolate cyst, you think endometriosis occurring in the ovaries. So what about a stromal hyperthericosis? This is a non-cancerous bilateral ovarian enlargement. In obese postmenopausal women. Non-cancerous stromal hyperthecosis. Okay, it's excess androgen production is the problem. So you see hirsutism and the big one, virilization. Where else do you see virilization? That's right, polycystic ovarian disease. It's associated with two things: metabolic syndrome and acanthosis nigrans. I know that's kind of out in left field, but you need to know it. Maybe. And that's the non-neoplastic ovarian disorders. So now let's talk about non-malignant disorders of the scrotum and its contents. These include cryptochordism, variocele, hydrocele, spermatocele, and testicular torsion. So what is cryptochordism? It's development failure of a testes to descend into the scrotum. Failure of testes to descend into the scrotum. Now, with a normal descent, you have a transabdominal phase where Mullerian inhibiting factor, or MIF, causes testes to descend from the retroperitoneum to the pelvic brim. You also have an inguinoscrotal phase where HCG, or human chorionic gonadotropin, and androgens cause the testes to descend down the inguinal canal to the scrotum. So MIF only causes the testes to descend from the retroperitoneum to the pelvis, or the pelvic brim. It's HCG and androgens that cause the testes to descend down from the inguinal canal to the scrotum. Now, undescended testes are more commonly, about 80% actually, found in where? The inguinal canal, but can also be intra-abdominal, but they're usually 80% of the time found in the inguinal canal. You need to know that. That's where you're going to find them. Many spontaneously descend by 3 months of age. So increased estrogens and increased HCG can correct the problem. After 3 months, it is unlikely that they will descend. Orchoplexy must be performed between 6 months and 2 years to remove the testicle. Orchiopexy. So what are the complications if a cryptochordism is not removed? Well, there's an increased risk of germ cell tumors, especially a seminoma. Make sure you remember that. Okay. You also get complications with impaired fertility because of the increased temperature of the undescended testicles arrests spermatogenesis bilaterally, and you can also have a torsion. So what is a varicocele? Well, a varicocele is a dilated vein in the pampiniform plexus of the spermatic cord. So a varicocele, dilated vein in the pampiniform plexus. Of the spermatic cord. Now, a varicocele is most common on the left or the right side. The left. Most common on the left side. A left spermatic vein drains to the left renal vein. So the left renal vein crosses under what? That's right, the superior mesenteric artery before it empties into the IVC. Now, the superior mesenteric artery can compress the left renal vein, ending in and that causes occlusion, aka the nutcracker effect. So you can get a left-sided renal cell carcinoma invading the left renal vein, and that can also cause occlusion. Renal cell carcinoma, you need to know that. So what about the right spermatic vein? It drains directly to the IVC. So the right-sided vein pathology does not cause right-sided varicoceles, okay? Right-sided renal vein pathology does not cause right-sided varicoceles. With the right spermatic vein, you can have retroperitoneal fibrosis or IVC thrombosis that can cause right-sided varicoceles, okay? But not the right-sided renal vein. Right-sided varicoceles warrant workup for a right-sided retroperitoneal mass. That's what you need to know. The signs and symptoms is visible dilated veins, and your clue or your buzzword there is it looks like a bag of worms. Bag of worms. It enlarges when standing and regresses when supine because of venous pooling. You get an aching pain, dragging sensation in the testicle, and you get an increased scrotal warmth, which leads to decreased spermatogenesis and infertility. So how do we diagnose a varicocele? You diagnose it with an ultrasound. That's a varicocele, so let's talk about a hydrocele. This is the most common cause of scrotal enlargement. So a hydrocele is the most common cause of scrotal enlargement. Okay, so the tunica vaginalis. The tunica vaginalis fails to obliterate proximally, which leads to a peritoneal fluid that can fill and cause distension. So you can get an indirect inguinal hernia. Also through this defect. It can be secondary to infection or to lymphatic blockage by a, what would cause lymphatic blockage? A tumor. That's correct. So how do we diagnose a hydrocele? Well, you diagnose it with something called transillumination. Transillumination plus an ultrasound. But transillumination is what you're going to be tested on. So what about a spermatocele? Well, this is something called a sperm-containing cyst. Sperm-containing cyst. It's a dilated epidermal efferent duct containing blocked sperm. A dilated epidermal efferent duct containing blocked sperm. How do you diagnose this guy? The same way you do a hydrocele. You do a transillumination and an ultrasound. So let's talk about testicular torsion. This is a twisting of the spermatic cord associated with vascular occlusion. So we're talking about ischemia here. The causes are trauma, physical activity, and cryptocoid testes. The signs and symptoms of testicular torsion is a sudden extreme pain, as you might imagine. The testicle is pulled up into the inguinal canal. So what test would I do to confirm a testicular torsion? Well, you would do the cremaster reflex, and what would I see? It would be absent. The cremasteric reflex would be absent in a testicular torsion. If it does not remit, surgery is required within 12 hours. Surgery within 12 hours to save the testicle from hemorrhagic infarction. So that is non-malignant disorders of the scrotum and its contents. Now let's talk about ovarian germ cell tumors. Germ cell tumors are the second most common type of ovarian tumor. Second most common type of ovarian tumor. They comprise approximately 20% of all ovarian tumors. You get a mature, so the most benign germ cell tumor is something called a mature teratoma. That is the most benign. And the most common malignant germ cell tumor is called a dysgerminoma. Actually, I've already got that written in there for you. Dysgerminoma. That's the most common malignant germ cell tumor. So a dysgerminoma is homologous to a testicular seminoma. It's the most common malignant germ cell tumor. So you might want to remember that for sure. It's associated with streak gonads of Turner syndrome. That explains why patients with Turner syndrome must have their ovaries removed, right? Because we don't want them to get a dysgerminoma. Histology shows sheets of uniform cells. They're usually round or ovoid with a clear cytoplasm. And tumor markers include a high HCG and a high, this one might throw you, LDH. So now let's talk about a teratoma. This is a tumor containing a tooth. Yeah, that's how you can think of it. A tumor containing a tooth, a teratoma. It demonstrates tissue elements derived from all three embryonic layers. So yeah, all three embryonic layers. So that's the endoderm, the mesoderm, and the ectoderm. Now, which one gives rise to thyroid tissue? The endoderm, that's right. What about bronchial tissue? Also the endoderm, very good. What about cartilage and bone? The mesoderm. What about the skin? Neural tissue, hair, that's the ectoderm. Alright, very good. So a mature teratoma, or a dermoid cyst, is the most common benign ovarian germ cell tumor. A mature teratoma most benign ovarian germ cell tumor. That's a mature teratoma. The immature type is rare, but it's aggressive and malignant, and it's usually squamous. You get a struma ovaria, which is mostly thyroid tissue, which leads to hyperthyroidism. If a patient presents with a unilateral, and this is important, remember this, if a patient presents with a unilateral ovarian mass and symptoms of hyperthyroidism, what are you going to be thinking from what we just have talked about? Struma ovaria. Struma ovaria. And how are they going to present? If a patient presents with a unilateral ovarian mass and symptoms of hyperthyroidism, think struma ovaria, because struma ovaria is mostly thyroid tissue, which leads to hyperthyroidism. It's very good. So let's talk about a yolk sac endometrial sinus tumor. What do we know about these guys? Well, they're an aggressive malignancy in the ovaries or testes in the boys and the sacrococcygeal area of young children. The tumor markers include an increased alpha-fetoprotein, and histology shows Schiller-Duval bodies. Schiller-Duval bodies. Alright, and they resemble glomeruli, so that's a pathognomonic finding. Alright, and then the last thing we're going to talk about is choriocarcinoma. Remember, it was a gestational trophoblastic disorder with the choriocarcinoma, and how did you recognize it? It had highly increased HCG levels. It responded to methotrexate, and what did it metastasize to? That's right, the lungs. Very good, choriocarcinoma. So ovarian sex cord stromal tumors. So we got a fibroma, which is a solid tumor consisting of bundles of spindle-shaped fibroblasts, and it's associated with Meigs or Meigs syndrome. Meigs syndrome or Meigs syndrome has three things associated with it. It's ovarian fibroma, ascites, and pleural effusion. Alright, and Meigs syndrome can present with a pulling sensation in the groin, so that's usually how they present. And that is a fibroma. What was it? It's a solid tumor consisting of bundles of spindle-shaped fibroblasts, hence fibroma. Now, a granulosa cell tumor is kind of a cool tumor. It's an estrogen-secreting tumor. Now, the clinical hyperestrogenism presentation depends on the age. So, number one, in young girls, it's going to present with precocious puberty. And in menstruating women, you're going to have irregular cycles. Because when should estrogen be the highest? That's right before the LH surge and at the end where progesterone's taken over. And in postmenopausal women, you can see vaginal and endometrial bleeding. All right, in adults is associated with endometrial hyperplasia or endometrial carcinoma. It shows something called Call-Exnar bodies, which are small follicles filled with eosinophilic secretions. That's Call-Exnar bodies. Call-Exnar bodies, which are small follicles filled with eosinophilic secretions. So that's granulosa cell tumors for you. So now let's move on to ovarian surface epithelial tumors. So there's 5 important characteristics here. They tend to occur in older people. Risk factors include the BRCA1 mutation or the Lynch syndrome, which was the HNPCC. The risk decreases by over-the-counter OPCs or pregnancy, or over-the-counter birth control or pregnancy. And the malignant types seed the peritoneal cavity. Now the tumor marker for this guy is an increased serum CA-125. That's the increased serum marker for him. Now, surface epithelial tumors comprise approximately 60% of all ovarian neoplasms. 60% of all ovarian neoplasms. And 80 to 90% of all malignant malignant ovarian neoplasms. So, what is the most common benign ovarian tumor? That's called a serous cystadenoma. That is the most common benign ovarian tumor. Serous cystadenoma. So what's the most common malignant ovarian tumor? A serous cystadenocarcinoma. Most common malignant. So serous tumors like cystadenomas are benign and cystadenocarcinomas are malignant. These tumors are often bilateral, the most common benign and malignant ovarian tumors overall. The serous cystoadenoma is lined with ciliated cells just like the fallopian tube is. Now, the serous cystoadenocarcinoma histopathology, you might want to remember these. You're going to see psammoma bodies, which is metastatic or dystrophic calcification. That's right, dystrophic, because it's not in the blood, right? We're not raising the serum calcium level. So you're going to see psammoma bodies. And you're also going to see invasive papillary histology. Alright, so now let's talk about mucinous tumors, which is cystoadenoma and cystoadenocarcinoma. These are unilateral. Mucinous tumors are unilateral, solid, and often large. They're usually greater than 10 centimeters for cystic tumors. They're lined by endocervical-like mucinous cells. Now, the mucinous cystoadenoma is a multiocular cyst lined by mucin-secreting columnar epithelial cells. It's filled with mucinous material, basically. But the thing I want you to remember is the mucinous cystadenocarcinoma. It can rupture and produce something called a pseudomyxoma peritonea. So, a pseudomyxoma peritonea, which is a copious mucinous ascites and peritoneal mucosinous tumors. More often, pseudomyxoma peritonea is caused by the appendix. And remember, that is not with mucinous cystadenoma, that is with a mucinous cystadenocarcinoma. Okay? So the last thing we have to talk about here is called a Brenner tumor. A Brenner tumor. Now he is benign. Okay? He is a benign tumor. He is characterized by Woodhard's rest, which is islands. Let me write that in there for you. Woodhard's rest, which is islands of bladder-like transitional epithelium. Within a fibrous stroma. So that is a Brenner's tumor for you. He's benign and he's got bladder-like transitional epithelium. That's important and that's what you need to remember. So that is ovarian surface epithelial tumors. So now let's talk about penile pathology. Alright, so we have some congenital disorders here. You have hypospadias, which is more common than epispadias. The urethral folds fail to fuse completely. Alright, and that causes external urethral orifices to open on the ventral surface. Make sure you heard that. That causes, because the urethral folds fail to fuse completely, you get an external urethral orifice that opens on the ventral surface of the penis. It's associated with chordee. That's spelled C-H-O-R-D-E-E, chordee, which is poorly developed penis that curves ventrally. Surgically corrected is usually done to prevent UTIs. Alright, then we have epispadias. Now, epispadias is associated with extrophy. Extrophy. It's a faulty position of the genital tubercle. During development. So the external urethral orifice opens on the dorsal, not ventral, dorsal surface of the penis. And it's associated with extrophy of what? The bladder. extrophy of the bladder. Now, then we go to squamous cell carcinoma. Squamous cell carcinoma has an increased risk with HPV 16 and 18 and other venereal diseases in uncircumcised males who exhibit poor hygiene. Okay, so you have something called Bowen's disease. You have something called erythroplasia of Curat. Then you have boinoid papulosis. And then you have penile squamous cell carcinoma. Alright, so what is Bowen's disease? It's carcinoma in situ that may invade. It presents as a single erythematous plaque on the shaft of the penis or the scrotum. So it presents on the shaft or scrotum. Alright, and it usually affects men greater than 40. It's associated with visceral malignancies. So men greater than 40 and visceral malignancies. Alright, so erythroplasia of Curat is carcinoma in situ that also may invade. Now this is also a single erythematous plaque involving the mucosal surface of the glans penis or prepuce. That's the end of the penis. Now this usually affects men over 40. Okay, and it's similar to Bowen's disease, but no increased risk of visceral cancer. Now, what about boinoid papulosis? This is carcinoma in situ that does not invade. Okay, so these two invade, and boinoid papulosis does not invade, even though it is a carcinoma in situ. It's a wart-like red-brown varicoid, so it's multi-pigmented. And it's got a red-brown varicoid, which is a wart-like lesion resembling a condyloma acuminata on the external genitalia, and it usually affects younger men. Now let's talk about penile squamous cell carcinoma. This is uncommon in the USA. It's very, very, very rare in circumcised individuals, but it occurs most often on the glans or mucosal prepuce. Alright, and that is penile pathology for you. So let's talk about pregnancy complications. I didn't write this in there, but you can have pregnancy-induced hypertension. Let's talk about that first. Now, why would a pregnant woman become hypertensive? Because she's got a lot of estrogen floating around, and estrogen, if it's a muscle relaxant, should keep your blood pressure low. What happens is the liver, because of that estrogen, starts making a lot of proteins, and specifically angiotensinogen, or angiotensinogen. Well, when the baby becomes too big, and the calcium calmodulin system starts, he starts contracting, they release a lot of renin, and that renin goes to that angiotensinogen, converts it to angiotensin 1, which goes to angiotensin 2, which squeezes down, and now we get pregnancy-induced hypertension, and we call that preeclampsia. It's defined clinically as hypertension and proteinuria with or without edema, which develop in which trimester? The third trimester. You will be tested on preeclampsia. Now, the definitive treatment for preeclampsia is delivery of the baby, because the baby's the one that started this whole thing. Now, eclampsia is when you add a grand mal seizure to the preeclampsia triad, okay? So if she starts having seizures because of the hypertension, that is termed eclampsia. And what do you think the treatment for that is? Deliver the baby, okay? In less severe illness cases, you need to symptomatically treat in bed rest, salt restriction, monitor the hypertension. It affects about 7% of pregnant women from 20 weeks gestation to 6 weeks postpartum. There is an increased incidence in patients with pre-existing diabetes, hypertension, chronic renal disease, and autoimmune disorders. Those are the four: diabetes, hypertension, chronic renal disease, and autoimmune disorders. And like we talked about, the etiology involves placental ischemia secondary to lack of trophoblastic invasion of the spiral arteries in the myometrium. So that's a fancy way of saying what we just did before. Now, it can be associated with something called HELP syndrome. This is on boards too a lot. HELP syndrome, which stands for hemolysis, elevated liver function test, and low platelets. That's HELP syndrome. So eclampsia is a medical emergency, and what do we give for an eclamptic patient? Does anybody know the two drugs we give? You probably know one, but what's the other one? Treatment is mag sulfate and diazepam or Valium. So that is pregnancy-induced hypertension. So let's go on to abruptio placenta. A lot to talk about with these. So abruptio placenta is a retroplacental clot that causes premature separation of the placenta from the endometrial implantation site. So premature separation of the placenta. Change my color back to red there. From the endometrial implantation site. So what is the number one risk factor for abruptio placenta? Hypertension. Hypertension, but also smoking, cocaine use, previous abruption, or an older mother. All of those happen. Now, the clinical presentation is usually in the third trimester, and it's painful uterine bleeding, as well as tetanic contractions. Now, it may be associated with DIC, okay, disseminated endovascular coagulation. So how do you manage this? You do not perform a pelvic exam. So the management. Let's go into boards 2 because this is where this is usually asked. Do not perform pelvic exam. How do you diagnose it? You diagnose it with an ultrasound. And you must deliver the baby immediately because there is a high mortality rate, okay? So that is abruptio placenta. So let's talk about placenta accreta. So placenta accreta is when the placenta is implanted directly in the superficial myometrium. Into the myometrium, which is the decidual layer that is defective. So the risk factors for this guy include endometrial inflammation, that's the big one right there. Scarring, that's also a big one. Scarring from like maybe a prior C-section is what I mean like by that. So yeah, inflammation and scarring definitely cause a risk for placenta accreta. Now the risk for impaired placental separation after delivery leads to massive postpartum hemorrhage and usually requires a hysterectomy. Okay, so that is placenta accreta for you. So let's talk about placenta increta. Now, placenta increta is a little bit easier. It's basically when the placenta invades the myometrium versus placenta percreta, where the placenta invades through the myometrium into the uterine serosa. Okay, so placenta increta is just when the placenta is invading the myometrium. That's all I want you to remember. Okay, so what about placenta previa? This is when the placenta attaches to a lower uterine segment. When the placenta attaches to a lower uterine segment, it may cover the cervical os. So it can coexist with placenta what? Accreta, and usually presents with painless bleeding in the third trimester. Okay, painless bleeding in the third trimester. Start thinking placenta previa, placenta accreta, etc. Now, usually there's a history of previous cesarean section, and that's a big risk factor. You do not perform a pelvic exam on placenta previa, just like abruptio placenta. You diagnose it with an ultrasound. That's important. So see, there's a lot of overlap here. Now, you follow the pregnancy closely and deliver it through C-section to avoid what? Maternal bleeding. All right, very good. So let's talk about ectopic pregnancy. This is most often occurring in where of the fallopian tube? The ampulla. Ectopic pregnancies usually occur in the ampulla. It can also occur in the ovary, the peritoneal cavity, and the cervix, but most commonly in the ampulla of the fallopian tube. That's what you'll be tested on. Now, risk factors. The most common cause is scarring from chronic salpingitis or pelvic inflammatory disease. Most common cause. Other causes include history of prior ectopic pregnancies or prior tubal surgeries. Now, the clinical presentation of ectopic pregnancy is a sudden lower abdominal pain with or without vomiting. So it's often mistaken for what? Appendicitis. That's right. But you also get an adnexial tenderness. Okay, that's important. So there's uterine bleeding beyond 6 weeks. The uterine pregnancy test must be ordered However, a positive result does not exclude appendicitis, okay? So the serial HCG levels. HCG levels generally rise at a slower rate than in normal pregnancy with ectopic pregnancy. They rise a little slower, so they're not going to be elevated. Because of this, serum HCG levels can be compared to the normal if ectopic pregnancy is suspected. Inappropriate low HCG levels, you think ectopic pregnancy until proven otherwise, okay? Low HCG levels, think ectopic pregnancy until proven otherwise. Note, inappropriately high HCG levels. From what we've talked about, what causes extremely high HCG levels? Molar pregnancies. So how do we diagnose ectopic pregnancy? You diagnose it with an ultrasound. So you're going to get a lack of intrauterine pregnancy. Now, complications may commonly arise from a rupture of the fallopian tubes, resulting in massive bleeding. So, number one, they can go into hypovolemic shock from intraperitoneal bleeding. That's the most common cause of hematosalpinx. Okay, don't even worry about that word. Hematosalpinx. The fetus almost never survives with ectopic pregnancies. So, that's ectopic pregnancies for you and pregnancy complications. So now let's go on to prenatal counseling and screening. All right. Doppler velocytometry determines blood flow in maternal and fetal vessels. Maternal and fetal vessels, and is an indication for a uteroplacental blood flow. Now, blood flow through the uterine, umbilical, and middle cerebral artery of the fetus are particularly important indicators of what? Fetal health. Uterine, umbilical, and middle cerebral, right? All right, very good. Ultrasound is used to detect structural abnormalities of the fetus. Now, the purpose of prenatal screening is to ensure an uncomplicated pregnancy and delivery. So, ideally, a woman should visit a doctor prior to becoming pregnant to identify any risk factors. So, maternal indications for further prenatal testing and monitoring include hemoglobinopathies, type 1 diabetes, hypertension, chronic renal disease, lupus or SLE, or antiphospholipid antibody syndrome, thyroid disease, etc. Pregnancy complications indicating the need for further testing and monitoring include preeclampsia, amniotic fluid abnormalities, multiple gestation, decreased fetal movement, and post-term pregnancy. So let's talk about the non-stress test. This correlates heart rate with fetal movements. Correlates heart rates with fetal movements. Now, normal or healthily results are active fetal movements cause an increased heart rate. Remember, the fetus has a higher heart rate than we do. Abnormal results may be due to many fetal complications, including acidosis or hypoxia and/or neurological depression. Okay, so now the fetal biophysical profile combines the non-stress test with a sonogram. To test 5 criteria that correlate with the fetal well-being, and those 5 are: number 1, fetal heart rate acceleration. Number 2, fetal breathing. Number 3, fetal movement. Number 4, fetal tone. Number 5, amniotic fluid volume. Each criterion receives a score from 0 to 2. Okay? If two separate scores in the same day are less than 4, it's an indication for immediate delivery. Less than 4 equals delivery. Alright, and that's prenatal counseling and screening. So now let's talk about genetics of prenatal screening. So maternal screening for infectious disease allows for proper treatment of the fetus and the newborn. So we're screening for hepatitis B, the group B strep, which a lot of women are carriers for, HIV and AIDS, rubella, and like syphilis, gonorrhea, chlamydia trachomatis. So that's usually what we're screening for. Methods for obtaining fetal genetic material for analysis include chronic villus sampling, amniocentesis, and sampling fetal blood. Now, in villus sampling, chororhinic villi are aspirated between 10 and 12 weeks gestation and undergo cytogenetic analysis. Now, in amniocentesis, it removes amniotic fluid, which contains fetal urine, exudate, exfoliated cells, and secretions. Now, that's generally performed within 15 to 17 weeks gestation. And what was villus sampling again? That was 10 to 12. 10 to 12 weeks. Alright, in addition to genetic testing, amniocentesis can screen for blood type, hematologic disorders, and also neural tube defects. Sampling fetal blood can screen for genetic or metabolic abnormalities. The primary risk of these techniques is damage to the fetus and inducing abortion. Now, the first trimester combined test is used to screen for two things. Trisomy 21, so first trimester, trisomy 21, and trisomy 18, or Edwards syndrome. Now, measures of maternal serum levels of HCG, pregnancy-associated plasma protein A, or PAPA-A, and fetal nuchal translucency are also known as NT. So in trisomy 21, you'll see an increased HCG, decreased PAPA, and an increased NT. Okay? Now, in trisomy 18, you'll see a decreased HCG, a decreased PAPA, just like in the other one, and an increased NT. So, what's that tell you? The number one thing you look at here is this bad boy, HCG, because he's the only difference. Alright, so a quad screen performed in the second trimester can diagnose trisomy 21 as well. The second trimester, you get a decreased alpha-fetoprotein, an increased HCG, a decreased urine unconjugated estriol, and an increased inhibin. Okay? Now, vitamin and mineral levels become increasingly important for an expecting mother due to adverse effects of nutritional deficiencies of the fetus, particularly iron and folate. Okay? Adequate folate is important for prevention of what? Neural tube defects. Iron requirements increase due to the increased demand of hematopoiesis of both the mother and the fetus. Now, let me ask you something. Pregnant women are advised to avoid cat litter, alcohol, soft cheeses, and unpasteurized milk. So, why would a pregnant woman avoid cat litter? Well, Toxoplasma gondii is found in cats, and that can cross the placenta and cause congenital toxoplasmosis, which is a triad of hydrocephalus, chorioretinitis, and intracranial calcifications known as ring-enhancing lesions. So we don't want to do that. The alcohol causes fetal alcohol syndrome and decreases the absorption of folate, contributing to neural tube defects. So what about the soft cheeses and unpasteurized milk? They're often infected with what? Listeria monocytogenes, which causes amnionitis, which causes neonatal sepsis, and meningitis, which causes spontaneous abortion. So that is why they should avoid those things. So that's prenatal screening genetics. Let's talk about prolonged estrogen stimulation. Prolonged estrogen stimulation, an increased level of total unopposed estrogen increases the risk for breast and endometrial cancer. Recall that estrogen governs the follicular phase of the menstrual cycle where endometrial proliferation occurs. So if you get stimulated by estrogen too long, you could easily end up with endometrial cancer. Thus, increased estrogen causes endometrial hyperplasia, which is a risk for endometrial carcinoma. Now, prolonged estrogen stimulation can occur in many ways. An increased time span of menstruation, usually in early menarche, late menopause, nulliparity, chronic and ovulatory menstruation. Endogenous or exogenous estrogen sources include ERT or estrogen replacement therapy, estrogen oral contraceptive pills, or granulosa tumor of the ovary, remember which we talked about, secretes estrogen. Now, an increase in estrogenic precursors include obesity, because fat increased aromatization of androgens leads to increased estrogen. And another one is polycystic ovarian syndrome, where pathologic increases in what hormone? LH increases androgen production, which is aromatized to estrogen. Very good. So that is prolonged estrogen, and remember, it's a muscle relaxant, so you're going to see hemorrhoids, low blood pressure. You can tie it into the liver, where you're going to see increased TBG with hypothyroidism, or hypothyroidism, so you might have to up their dose, etc., etc., etc. They could have hemorrhoids, they could have facial flushing, pulmonary edema, spider nevi, etc. So that's prolonged estrogen. What about the prostate pathology? So the prostate pathology, that includes prostate-specific antigen, or PSA. That's elevated in prostatitis, BPH, prostate infarction, and prostate adenocarcinoma. And those are the four things we're going to talk about. There are better ways to report prostate-specific antigen, as, for example, increased circulating free PSA, you see that is associated with benign prostatic hyperplasia. Increased circulating bound PSA is associated with cancer if it's bound. Now, the PSA velocity which yearly increases greater than 0.75 with normal baseline PSA indicates increased cancer risk. Now, prostate density. That accounts for different prostate volumes, okay? So as promised, we're going to discuss prostatitis. That presents with pain in the lower back, and usually in the perineal area. Other symptoms include dysuria, frequency, urgency, possible hematuria. If it's acute, it's associated with cystitis or fever. Usually if they're less than 35 years old, it's chlamydia trachomatis or Neisseria gonorrhea. If they're older than 35 years old, it's usually E. coli, Pseudomonas aeruginosus, or Klebsiella pneumonia. The chronic form instead of the acute form of prostatitis is more common. And this is usually abacterial, so usually cyclists get this. But it can be bacterial from acute and progress to chronic. So chronic abacterial prostatitis is the most common form. Chronic abacterial prostatitis is the most common form, and patients have no history of recurrent UTIs. Prostatic secretions contain leukocytes but no bacteria. So what about BPH, benign prostatic hyperplasia? It's not considered a pre-malignant lesion, but does have an increase in free prostate-specific antigen. It's present in about 50% of 50-year-olds and 80% of 80-year-olds, so 50-50, 80-80. It develops in prostatic, periurethral, and transitional zones. Okay, remember that, periurethral and transitional zones. Now, what causes this hyperplasia of this stromal or periurethral and glandular cells? Dihydrotestosterone, DHT, causes hyperplasia of the stromal, which is the periurethral, and glandular, which is the transitional cells. So you get a soft, rubbery nodule formation. Now, increased estrogens in older men may promote prostatic growth by increasing androgen receptor expression. So the complications include post-renal azotemia or failure, bilateral hydronephrosis, bladder diverticuli, and smooth muscle hypertrophy, and a predisposition to infection due to urine stasis. Note, BPH does not increase the risk for prostate cancer. The treatment is to avoid caffeine, alpha blockers, relax smooth muscle tone, 5-alpha reductase inhibitors decrease conversion of testosterone to DHT, so that's a great thing, and transurethral resection of prostate if necessary. Now, prostatic adenocarcinoma we're going to talk about. Prostatic adenocarcinoma is the most common cancer in adult males. Remember that, you will be tested on that. It's not including skin cancer because skin cancer is the most common cancer in the United States. It's usually with men greater than the age of 40. Now it develops in the prostatic peripheral, not transitional, peripheral zone. Peripheral zone of the prostate. Number one, it's palpable on digital rectal exam. It feels like a hard knuckle. Number two, there are no urinary symptoms until advanced disease. That is important. There's no urinary symptoms. Until advanced disease. Now, the risk factors include a first-degree relative with history, African American descent, cigarette smoking, advanced age, and a high-fat diet. Now, the spread is through the perineural invasion to the lymphatics, and then it gets hematogenous. So, osteoblastic bone mets are by far the most common. So, other common metastasites include the lung and the liver. And the tumor-specific markers is an increased PSA, decreased fraction of free PSA, and an increase prostatic acid phosphatase. With invasion. So the diagnosis is transrectal needle core biopsy, and the treatment is surgery, radiation, and hormone therapy. Tumor cells are DHT dependent. And that is prostate pathology. So what about sex chromosome disorders? We have Klinefelter's, Turner's, XYY syndrome, and Fragile X syndrome. So Klinefelter's is about 1 in 850 people. It's 47XXY. And it's the most common cause of hypogonadism and infertility. The cause is meiotic non-disjunction. Meiotic non-disjunction. The pathophysiology, I'm going to just tell you well, I'll go through it, but I'll write down what you need to know. It's fibrosis of the seminiferous tubules, which cause a loss of Sertoli cells, which decrease inhibin. Okay? Sertoli cells are inhibin dependent. So if you have a decreased inhibin, you're going to have an increased FSH because you get a loss of negative feedback. If you have an increased FSH, you're going to have an increased aromatase in what? The Leydig cells. If you have an increased aromatase, that converts testosterone to estradiol, and that's what causes the feminization. Okay, it's the increased aromatase from the FSH. And you're going to have a decreased testosterone, which is going to increase the LH, which is going to give you loss of negative feedback again. So the increased LH often leads to increased estrogen. So what's the overall hormone levels going to look like for Klinefelters? They're going to have decreased testosterone. They're going to have increased FSH, an increased LH, and an increased estrogen. So the one to pay attention for is the decreased testosterone. Now the clinical presentation is due to unopposed estrogen. So you're going to get testicular atrophy, azoospermia. You're going to get a female distribution of body hair. They're going to usually have a tall stature. Fusion of the epiphyseus is delayed, and that's why they get a tall stature. And it's associated with mental retardation. Severity correlates with an increased number of X chromosomes. Now, the karyotype for diagnosis must be ordered. So the male with the genotype 47XXY caused by meiotic disjunction, you're going to get buccal smear preps, usually showing single bar bodies. Single bar bodies, which is an inactivated X chromosome. Okay? So let's talk about Turner syndrome. So Turner syndrome is about 1 in 3,000, and it's going to be 45XO in females, and it's the most common cause of primary amenorrhea. Most common cause of primary amenorrhea. Now the causes are, there's two of them. In about 60% of cases you get meiotic non-disjunction. In about 40% of the cases you get a mosaicism between the 45X and the 46XX karyotype. Now the clinical presentation is primary amenorrhea with streak gonads. Streak gonads. Symptoms due to the missing second X chromosome. So bar bodies are present. They have oogenesis and normal sexual development, but that does not occur. They have a short stature, and they have menopause before menarche, and they have an increased risk for ovarian dysgerminoma. That's why their ovaries are removed, like we talked about earlier. And that's why they're removed early. Other clinical findings include a bicuspid aortic valve, preductal aortic coarctation, that usually leads to upper hypertension and lower hypotension, and so you're going to see rib notching. Now they have a normal intelligence, but they also have lymphedema and dilatation and a cystic hygroma, a cystic hygroma is the web necking. That's all cystic hygroma means. They also have hypothyroidism and a horseshoe kidney. So let's talk about the XXY syndrome. This is about 1 in 1,000, and it's 47 XYY males with aggressive behavior. Its cause is of paternal non-disjunction. Paternal non-disjunction. So they have increased height and sometimes mild mental retardation. They have a normal fertility, though. It used to be thought that XYY syndrome correlates with an increase in aggressive behavior, but newer studies have found not such an association. So, but for the boards, just think aggressive behavior with XYY syndrome. And then we got Fragile X syndrome. This is the most common cause of inherited mental retardation. Inherited. Fragile X syndrome, the most common cause of inherited mental retardation. A lot of people don't know that. And I note Down syndrome is the most common genetic form of mental retardation, whereas Fragile X syndrome is the most common inherited form of mental retardation. It's caused by a cytogenic defect on the long arm of chromosome X. The expanded trinucleotide CGG repeat segment in the promoter region of the FMR1 gene, that's not high yield, but write it in there, enhances methylation. And when you enhance methylation, what do? You silence the gene. So that's what's going on. Now the chromosome appears to be broken, and hence Fragile X. It's associated with mitral valve prolapse and aortic root dilatation. It's seen in males and females. Males present with large ears and large jaws, as well as bilateral macroorchidism, which is enlarged testes. So that is the sex chromosome disorders. So now we're going to talk about testicular germ cell tumors. All right. So general characteristics. Testicular cancer usually affects men under 35. Men under 35. 95% of malignant testicular cancer is of germ cell origin. Now, germ cell tumors are classified as seminomatous or non-seminomatous. Seminomas are of a single cell type. However, most germ cell tumors are made up of more than one cell, i.e. several different non-seminomas. Now, what's the most common risk factor for testicular cancer? What do you think it would be? It's cryptocortism. That is the most common risk factor. Also, testicular dysgenesis, which you will see in testicular feminization syndrome or Klinefelter's, or family history. So those are the three main risk factors. The diagnosis is made with ultrasound or hypoectic intraintestinal mass on the CT, or the chest x-ray is used for staging. So let's talk about a seminoma. A seminoma is the most common malignant testicular tumor. It's about 40%. 40%. The histology is it's a clear polygonal germ cells with round nuclei and prominent nucleoli. It's arranged into lobules and surrounded by septae. and you see a lymphocytic infiltrate. You see a lymphocytic infiltrate and granulomas. Now, gross appearance, it's a bulky gray tumor without hemorrhage or necrosis. It does not have hemorrhage or necrosis. Signs and symptoms include painless testicular enlargement, that's big because it's painless, heaviness in the scrotum, pain in the abdominal and lower back, the periaortic node metastasis is why that's happening, and increased HCG levels are rare. It is radiosensitive. It's radiosensitive and often curable. Late metastasis with an excellent prognosis. So what about an embryonal carcinoma? This is sheets of undifferentiated cells with follicular glandular differentiation on papillary morphology. So a gross appearance is it's a bulky, hemorrhagic, and necrotic tumor. Whereas remember, seminomas was not. So it's a hemorrhagic tumor. It can continue to differentiate into other non-seminomas. Signs and symptoms, this one is painful. It's hemorrhagic. It's necrotic. Metastasis is usually hematogenously. You will see an increased alpha-fetoprotein and an increased HCG. Remember, that was rare in seminomas. So what about a yolk sac tumor or an endometrial sinus tumor? This is usually in children under 5. Children under 5, and it has a good prognosis. The histology, you will see Scheller-Duval bodies. And it gives you primitive glomerular structures. And this one you will see an increased alpha-fetoprotein. So what about choriocarcinoma? It's the most aggressive testicular tumor, and it has a poor prognosis. Now, histology, it has a mixed proliferation of trophoblastic cells, which are your syncytiotrophoblasts and your cytotrophoblasts. It's often mixed. That's important. It's often mixed with other non-seminomatous tumor types. Now, the gross appearance is it's a small primary tumor with extensive necrosis and hemorrhage. Extensive necrosis and hemorrhage. Now this one you will see an increased HCG in all cases, and it may present as gynecomastia. HCG has a similar structure to what? LH. So if you increased LH, you're going to get an increased breast development. It metastasizes hematogenously and mostly to the lungs and liver. Okay, so what about a teratoma? This affects all ages. It demonstrates tissue elements derived from all 3 embryonic layers, so the endoderm, the mesoderm, and the ectoderm. A mature teratoma in males is malignant and is often a squamous malignancy. It's interesting because the mature teratoma, which is a dermoid cyst in females, is benign. Very strange. 50% have an increased alpha-fetoprotein. And or HCG. So that is testicular germ cell tumors. Now let's go on to testicular non-germ cell tumors. And these are sex cord stromal tumors, which include Leydig cell and Sertoli cell tumors. Now, the Leydig cell, or the interstitial tumor, is a benign tumor that produces androgens or estrogens. It presents with precocious puberty in boys and gynecomastia in men, and it is characterized by intracytoplasmic Renique crystals. Renique crystals, which are rod-shaped crystals. So now, Sertoli cell tumors are also a benign sex cord stromal tumor. About 1/3 are hormonally active and may produce estrogen, which is going to give you gynecomastia, or testosterone, which is going to cause precocious puberty. So that is Sertoli and Leydig cell tumors. What about testicular lymphoma? Overall, this is a rare cause of testicular cancer, but is generally found in men greater than 50, and is the most common form of testicular cancer in men greater than 60. That is important. Most common cause of testicular cancer in men greater than 60. It can be a primary lymphoma arising from within the testicle, or it can be metastatic disease from other parts of the body, like a lymphoma leads to most common secondary testicular cancer, which is usually bilateral, or you can get a diffuse large cell non-Hodgkin's lymphoma type. So that is your non-germ cell tumors. So now let's talk about tumors metastatic to the ovary. And these frequently are of the gastrointestinal tract, the breast, or uterine in origin. So, gastric metastasis to the ovary is known as a Kronkenberg tumor, and they love this on the boards. Remember that, Kronkenberg tumor. That's highly tested. The stomach has a rough water bottle appearance due to thickening of the wall. The histological appearance, you will see signet ring cells, and mucinous cells. And it also has a hematological spread. So that's tumors that are metastatic to the ovary. Just remember the Kronkenberg tumor. All right, uterine pathology. So endometritis is the most common genital tract infection following delivery and abortion, especially in preterm deliveries. So the signs of that are going to include fever, lower abdominal pain, vaginal bleeding or discharge, or foul smelling loci. So what about endometriosis? This is implantation and proliferation of ectopic, non-neoplastic, hormonally responsive endometrial glands and stromal tissue. So you get cyclic bleeding. Cyclic bleeding. Cyclic symptoms according to the hormonal status is why this happens. So an example, symptoms may worsen leading up to menstruation. Now, women in their 20s and 30s may present with infertility in the 3Ds. And that is dysmenorrhea, dyspareunia, which is painful sexual intercourse, and dyschezia, which is painful defecation. Now, the most common sites of endometriosis are at the adnexa, um, the rectouterine pouch of Douglas, and the bowel, bladder, and peritoneum. There are two possible mechanisms for endometrial tissue dissemination. Number one is, it's just a theory, it's a metastatic theory. Menses reflux into the fallopian tubes, causing vascular and lymphatic spread. And number two, the metaplastic theory, says glands and stromal tissue can arise directly from pelvic or abdominal mesothelium. But we don't really know what's going on there. So let's talk about adenomyosis. This is islands of endometrial glands within the myometrium. Okay? Let's write that in there. Islands of endometrial glands within the myometrium. Okay, and it presents with menorrhagia and dysmenorrhea, and it's a symmetrically enlarged boggy uterus. So if you ever hear that term, boggy uterus, think adenomyosis. You diagnose it with a biopsy, and what do you think the definitive treatment is? That's right, hysterectomy. So that leads us into endometrial hyperplasia. This is an abnormal proliferation of endometrial glands caused by excessive estrogen stimulation. So there's so many risk factors for endometrial hyperplasia, and I think we have went through them, like granulosa cell tumors, polycystic ovarian disease, late menopause, early menarche, tamoxifen, which is a partial agonist of estrogen receptors in endometrial tissue, etc. I mean, we could go on forever. Endometrial hyperplasia usually presents as postmenopausal vaginal bleeding. Endometrial hyperplasia usually presents as postmenopausal vaginal bleeding. So endometrial hyperplasia is a precursor to what? Endometrial carcinoma, where patients with endometrial hyperplasia are at an increased risk of developing endometrial carcinoma. And speaking of endometrial carcinoma, this is the most common gynecological malignancy. It manifests clinically by postmenopausal vaginal bleeding, and it peaks between ages 55 and 65. So if you have vaginal bleeding in a woman 55 to 65, it is endometrial cancer until proven otherwise. Now, the risk factors include prolonged unexposed estrogen exposure, diabetes, hypertension, tamoxifen treatment, and HNPCC. Now, the prognosis correlates with the degree of myometrial invasion. So think of its progression as an uncontrolled proliferation or follicular phase of the menstrual cycle. So you have a normal endometrium, so then you get simple hyperplasia, which leads to complex hyperplasia, which leads to atypical hyperplasia, which leads to a frank adenocarcinoma. So what are the treatments? Well, for simple hyperplasia, you can do oral contraceptive pills. For atypical hyperplasia, you got to do a hysterectomy. For an invasive carcinoma, you need some combo of surgery, chemo, and radiation. All right. Now, the most common tumor in women is a leiomyoma, or a fibroid myoma. Now, in general, please note that tumors are not necessarily malignant. So what is a fibroid? It's a benign proliferation of myometrial smooth muscle. So you're going to see whorled patterns of smooth muscle. Whorled patterns of smooth muscle on microscopic exam. Now the tumor which is well demarcated, meaning it's encapsulated by a pseudocapsule. The peak occurrence in women is usually between ages 20 and 40 years of age, and it does not progress. A leiomyoma does not progress to a leiosarcoma. Which is a very good thing. All right. And let's talk about a leiomyosarcoma. This is a bulky, irregular shaped tumor with areas of necrosis and hemorrhage, typically arising de novo, but not from a leiomyoma. You see an increased incidence in blacks, and it's a highly aggressive tumor with a tendency to reoccur. It may bleed or fungate from the myometrium into the lumen of the uterus, sometimes even protruding through the cervix. So what is a bicornicate uterus? It's a condition where the uterus has two horns entering a common vagina. The etiology is partial fusion of the paramesonephric ducts. It clinically can present with urinary tract abnormalities and infertility. And in pregnant women, a biconcave uterus is associated with increased risk in bleeding, spontaneous abortions, or premature delivery. And you've done a good job. So the last thing we're going to talk about is vaginal carcinoma. So squamous cell carcinoma of the vagina is most common, often due to extension of squamous cells of the carcinoma of the cervix. Okay? So what about clear cell adenocarcinoma? This is a rare malignant tumor increased in incidence of daughters of women who received diethyl stilbestrol therapy during pregnancy. That's clear cell adenocarcinoma. So what about, like in the picture, sarcoma botryoides? This is a rare variant of rhabdomyosarcoma. It occurs in children younger than 5 years of age. It presents as multiple polyploidal masses resembling a bunch of grapes. Which you can kind of see in this picture right here. Projecting into the vagina. It's often protruding from the vulva and yellowish in color. Histologically, it shows spindle-shaped tumor cells that are Desmond positive. And that pretty much covers reproductive pathology. So if you go over all that, I think you will be just fine.